school was kind of exposed to clinical reasoning and kind of the more specific definitions around it and how we do it. Okay, I see two hands. I'm like scrolling through. Okay, so not a lot of, well, maybe a handful. So not too many, which is, completely normal. Well, maybe not good, but normal. That's what happened to me in med school. So we'll sort of start from the basics and make sure we all have good definitions for some of the clinical reasoning terms like System 1 and System 2 thinking, illness scripts, problem representations. We'll go over all of those. And then I hope that the bulk of the session will actually be creating problem representations to kind of see how they activate our different thinking when it comes to a case. So starting from a 10,000 foot view about dual process theory. So you guys may have heard of dual process theory from that book, Thinking, Fast and Slow. And so what it's about is the fact that psychologists think that us humans have two different thought processes. There's one that's really automatic and implicit, and the other one is more controlled and explicit, and that we're more aware of. So in medicine, this was applied and called System 1 and System 2 thinking. And so what happens is that when clinicians are in front of a patient, there's a pattern there, right, of signs and symptoms. And so if the pattern is immediately recognized based on what that clinician is seeing, that activates System 1 thinking. And so it's very fast and automatic, and you arrive at the diagnosis. On the other hand, when the pattern is not recognized, you activate System 2 thinking, which is slow, analytical, and you still eventually get to the diagnosis, but it can just take a little bit longer. You probably will start out intern year more in System 2 thinking, right, as you kind of learn how different illnesses present. But over time, with experience, you will end up activating System 1 thinking. But there's obviously a caveat, right? System 1 thinking is fast and automatic and sometimes is more prone to biases. And so it is important for you to be aware when something doesn't fit, right? You've like immediately are like, oh, I know what's going on with this patient, but then there's a piece of it that that doesn't really fit. It's important to slow down and go back to System 2 thinking. And so really the hope is that throughout your residency and even throughout your training further down the line is that we become these master clinicians that are able to kind of navigate System 1 and System 2 thinking when appropriate. Does anyone have any questions about those concepts? Wonderful. Okay, so kind of taking another step back. So how do we kind of get to that pattern recognition step? And so that's where we're going to now talk about those problem representations and those illness scripts. So what happens is that when you see a patient in clinic or in the hospital, it's really key to actually consciously make a problem representation for yourself. So when you have that patient in front of you, you make that problem representation because that problem representation will activate a series of illness scripts for your differential. And then, of course, as you move on throughout the case in the hospital stay or throughout your journey with this patient in clinic, that patient presentation will evolve. You'll change your problem representation and a different differential might appear so that you can get to that pattern recognition. Any questions about those concepts? Okay. So again, just so we're all on the same page. So illness scripts, this is kind of the bulk of what we did in medical school. So we learned a bunch of different illnesses. We learned about the predisposing conditions. So kind of the epidemiology of an illness. We learned about the pathophys insult. So learning exactly about the pathophysiology and how long an illness takes to show up, and the clinical consequences. So the signs and symptoms, the diagnostics, and the treatment of this. And so, this probably looks like what you learned in medical school every day. And then during residency, these will become a little bit more nuanced over time. So, you know, your strict definition of what you thought a heart failure patient looks like will probably evolve over time. Any questions on that? Wonderful. I'm glad I'm being so clear. Okay,
Crystal.
so now to my favorite part is problem representation. So you all been doing problem representations in morning reports and or in your own clinical practice? Yeah, okay, I see some yeses. All right. And so I kind of gave it away, but when should you be using problem representations? And this is where you guys can talk.
Every time.
What'd you say?
Every time.
Every time. Yeah, that's great. Alex, I planted you. So yes, I want you to really consciously be doing this. And I think it's something that I don't do enough of, but really taking that step back and framing your patient in front of you will help you avoid biases that are always encircling us and really make sure we're being thoughtful clinical reasoners. So let's define problem representation. So it's a one sentence summary of a case that will answer 3 questions. So the first question is, who is the patient? So you're honing in on their demographics and their risk factors. And if Gabby was here, she'd tell you that for the demographics like age and gender, she really thinks for age, you can actually say the specific age. She doesn't really agree with the young, middle-aged, elderly definition. So feel free to do whatever you wish there. And again, gender too, you can decide whether or not you feel like it's relevant to the case. And then the risk factors, again, that's kind of what we consider our past medical history, but this time you're being very thoughtful about what you're including in there and whether or not you can lump, certain diseases together. The second question is, what is the temporal pattern of illness? So here you're really talking about the length of the illness. So using those very, what we call in clinical reasoning world, semantic qualifiers. It's kind of like medical jargon that kind of makes us think certain things. So there's hyperacute, acute, subacute, chronic, and also the tempo of the illness. So here you can see more semantic qualifiers that we use, like stable, progressive, waxing, and waning. And again, we are using these specific words because whether or not we know it, in our little brains throughout medical school, these words have been associated with certain illnesses in our minds. And so that's why we're being so specific about the words that we're using. And then the last question, and the hardest really part to answer, to be honest, is what is the clinical syndrome? So from your patient presentation, you're really picking out the key symptoms and signs, and lab values and imaging and whatever else you have that you really need to explain in order to understand what's happening to the patient. And that's not to say that your problem representation has to only evoke one diagnosis, right? Like a patient can have 2 different things going on. And I think the important part is to capture enough of everything that's going on that you're not missing anything. Any thoughts or questions or kind of things that you've seen in ambulatory morning report, or maybe when you have been in the hospital about problem representations that you found useful?
I feel like they can tend to be super long and all-inclusive, and sometimes that is distracting to me. I feel like kind of a shorter, more concise one is generally maybe activates more illness scripts than the super inclusive ones.
Yeah, Kim, I agree with you. I think especially in the beginning, it's hard to know what to include and what not to include. One of the things I do, which some people, again, this is all for your clinical reasoning, so whatever works, there's no real strict definition either way, but I don't include any pertinent negatives. Like I won't say afebrile or like non-bloody or whatever, because I assume if I didn't put it in there, it's not part of it. But again, it's all up to you and how your brain kind of thinks about it. Well, let's look at an example one before you all get a chance. So this is a 66-year-old man comes to clinic to establish care with a chief concern of shortness of breath for several months. At first, he notes it was mild, but now he can't walk to the mailbox without dyspnea. He feels fatigued. He has a history of MI and a 40-pack year smoking history. On exam, his blood pressure is 156/93. He has an S3, S4, diminished breath sound bilaterally, and edema in his lower extremities. Before I reveal my problem representation, think to yourself kind of what you think you would put. Okay, so mine was an elderly male with a history of coronary artery disease and hypertension who presents with chronic progressive dyspnea on exertion with evidence of volume overload on exam. Does anyone have anything different? You see some head shakes, no.
I feel like I almost want to add the smoking just because it could be like a non-heart related problem.
Yeah, I agree, Kim. I think that comes up every time, and it's like, right. I hear you. And you could, because then you would make sure COPD is not like off of your differential, and it's hard to say. Great. Okay. Well, now, what I want you guys to do is actually practice within groups. So you will be split up into 4 different groups. And Whitney, thank you, Whitney. She posted in the chat box the worksheet that lists all of the cases that you can download. Your group number will correlate to the case number that's on that worksheet. And when you guys get into your, sorry, I'm really working on not saying guys, but I keep doing it. When you are all in that group, someone should create a shared screen so that you all are on the same page when making your problem representation. And then we will reconvene in 7 minutes and then go over everyone's problem representations and kind of discuss the process of making them. Thoughts, concerns before Whitney breaks us up. I'll also be plopping into the groups randomly to kind of help if needed. Are we all on the same page? Okay, wonderful, Whitney. Feel free to split us up and then 7 minutes. Hello. Okay. Well, if you all felt really rushed, that's okay because usually there's 10 minutes, but I want to honor your 10-minute Zoom break at 10:50. So I made it shorter. So don't feel bad if you didn't have enough time. That's all right. This is a work in progress. Okay. So let's start with case. Actually, I have to share it a different way. Sorry, guys. I have to share it so I can actually annotate it. Oh, gosh. Oh, this is embarrassing. Okay. All right. Well, you know what? We're just gonna do it. Oh. Sorry, all the time I saved is gone. Okay. All right. Okay. So case number 1, you guys all see so that I can just type here. Okay. So if we could have a spokesperson for group 1 share their problem representation for us.
All right, we had slightly differing opinions on how to do this one.
Well, I'd love to hear them. Yeah.
So we had a 47-year-old male who presents with acute, and then we were kind of debating between saying a monoarticular versus a right knee pain, and then debating between inflammation versus like warm, tender. And then we're also debating, like, do we need to include on hydrochlorothiazide or binge drinking or not? We opted not to include those things.
So
we did one thing that we did mention, Kim, that we didn't put in there was progressive.
Oh yeah, sorry.
Okay. Well, this is going to be one of my pet peeves of semantic qualifiers. So what does arthritis mean?
Inflamed joint.
Yes. Don't you really hate osteoarthritis? Ugh, it's such a bad misnomer. So you could, in case this helps your brain, write acute progressive monoarthritis. And maybe to either to group 1 or to the whole group doesn't. If you just hear monoarthritis without any of the other risk factors, does that help? Is it hurtful or helpful for your differential?
I think generally, like, when you're thinking like monoarthritis, you have some ideas of what causes it would be, versus if you had somebody with like symmetric polyarthritis, that takes you down a totally different route.
So Kim, what I'm hearing is that you're different, like you're going to include all of those things anyways in your differential. So putting in like hydrochlorothiazide and alcohol to lead you more towards gout would be more harmful than helpful.
Yeah, like I don't know, I guess I'm thinking, like, if we include that stuff, then we're taking people down the gout pathway, but maybe that's a good thing if he has gout. But like if he had like a septic knee or something, then we would be misleading.
Yeah, I think that's fair. If you feel like someone might, or if you might just like totally forget about a septic knee, and because you're not including, because if you were to include all those gout risk factors, I think that's a good reason not to. What do other people think?
I feel like I would make a case for including, I don't know why, I'm like big on pain that wakes you up from sleep. Just because to me, that typically talks about more acute or like just more acute processes. So like I wouldn't be thinking that someone's gonna be waking up from their sleep in pain from like osteoarthritis. And so to me, I think it would help like limit and hone my differential personally. But I could see why, like, you would not potentially put it.
Yeah, I hear that. And even maybe the acute part, right? The fact that it's acute progressive, you don't think of osteoarthritis that much. Though I see like the bed sheet sign of like the gouty toe is pretty classic. So you're right. Well, as you guys can see, I think like this is going to be the kind of the point from each case is that like depending on what you include, maybe or maybe not, that kind of changes your differential, which is the whole point. Okay, so thank you, case 1 or group 1. All right, so let's go to case 2. What do we got?
So I think we said middle-aged female, originally from Cambodia, presenting with chronic intermittent cough, fevers, weight loss, and progressive dyspnea on exertion.
Chronic intermittent, sorry, can you say that was
Cough,
cough?
fevers, weight loss, and progressive dyspnea on exertion. So we were trying to think of like whether or not it was the benefit of trying to group some of those first few symptoms together into something. And so like, for example, if you were to say like B symptoms or something like that, I think our general feeling was that it would pigeonhole you too much down like a certain diagnoses without having the like information to back that up. And so it's just, in this case, better just to list them out. And we were kind of plus or minus on some of the night sweats in our group, like whether or not that was meaningful to keep in or keep out. Also, there was some discussion on whether or not the progressive dyspnea was worth keeping in or out as well.
Any thoughts from, I know you guys are all, sorry, I know you are all seeing the case 2 for the first time for the other folks, but anything, thoughts that come up reading it?
I think Alex has already mentioned that, but in this one, I would probably just say with chronic intermittent cough, progressive shortness of breath on exertion, and constitutional symptoms, or yeah.
Thanks, Saifu. I do appreciate, yeah, so maybe I really like that point, Alex, you're making, that B symptoms maybe leads us down too quickly down the cancer route, but maybe constitutional symptoms evokes more of a systemic illness. That's a great suggestion, Saifu, and I really appreciate you all being so thoughtful that you want to make sure that, I assume the Cambodia piece was included for like kind of thinking about TB, but you also don't want to forget about malignancy in this case. Wonderful. Any other thoughts before we move on to case 3? I guess the one thing I'll say, and only because I know what this case was hinting at, what did you feel about this chronic low back pain that has worsened in the last month? You chose not to include it as a discriminating feature in your syndrome.
Yeah, I mean, I guess if you are thinking about TB, that could be like a sign of like POTS or something like that.
Yeah. So I guess, and what made you choose not to include it?
I mean, I can't speak for other. I don't think we necessarily I don't know if we were as intentional about including it or not including it as perhaps we could have been. I think if we're thinking about TB, we would have perhaps gotten there regardless of whether or not they have low back pain. I think POTS is like a more specific sequela of TB. But yeah, I think it already kind of felt like we had a lot of symptoms in there and just didn't want to just keep on rattling off like every single thing that she's endorsing.
Yeah.
I don't know.
No. I think you're exactly, Alex, it's a really tough thing. And I think sometimes, at least when I'm thinking of these systemic illnesses, if you can hone in on certain organs that seem to be potentially getting more affected than others, it can be helpful for even your diagnostic workup, right? After you have the problem representation, you can kind of focus in, okay, I have the lungs and I have the back, like which one would be easier to go after potentially. But I agree. I mean, I think it varies, obviously this is my 3rd time doing it. It varies whether people are not included. It varies whether people include the AFib, right? It's all depends. Okay. Case number 3, what you got?
So we had middle-aged woman, with history of hypertension and alcohol use, presenting with acute severe abdominal pain with associated nausea and non-bloody, non-bilious vomiting. And we were discussing whether or not to include the radiating to the back as part of our problem representation. And in terms of the vitals that she had in the ED, we didn't think that they really represented hemodynamic instability necessarily, and didn't think it needed to be part of the problem representation.
Can I ask you what your kind of differential was for this patient?
I think on the top of my list would be like pancreatitis versus like cholecystitis, anything related to like the upper abdominal area.
I think also we didn't have enough time to finish our discussion.
Yeah, of course.
One of the things that I was thinking about is that the pain started pretty suddenly, like just 5 hours ago, which kind of makes it in the hyperacute scenario. And also with the vitals being the way they were, my top differential diagnosis that I wouldn't want to miss is like a rupturing aorta or something like that versus an acute pancreatitis, which makes management pretty different. If it's a rupturing aorta, then I would think about the hemodynamic instability of this, and my management would be different, would be more rushed compared to if it was an acute pancreatitis, which would be like let's put them on meds and some fluids and watch.
Yeah, I like that, Tam. Kind of, although it may or may not be GI related, making sure those can't miss diagnoses are represented. So which one, what do you think would be worth highlighting in the problem representation to kind of make sure that stays in the differential?
I think I would put down possibly hyperacute nature of the problem, and I would consider putting down hemodynamic instability. I don't know.
Yeah. Sometimes I agree with the like kind of whether or not the vitals are, the discussion about that. And I think you could, if it's not hemodynamically unstable, you could think of like highlighting the severe hypertension, right? Because that's when you think of aortic dissections a lot, is when someone's super hypertensive and they've dissected. And can I ask for, you have all highlighted the nausea, vomiting, and the non-bilious, non-bloody vomiting. Was that what were you kind of trying to highlight with those symptoms to make sure that, I guess, what do they help or do they hurt kind of your building of your differential?
I think it helps. Like parsing out a Mallory-Weiss tear, because it's got a history of alcohol use.
Right. I like it. Awesome. Okay, now last but not least, group 4. What you got?
So we said a young woman with history of depression and significant stress, and family history of sudden cardiac death, who presents with chronic progressive episodes of palpitations, shortness of breath, lightheadedness without volume overload.
Sorry, I missed the.
I said without.
And then who presents? And you said intermittent.
We said chronic, progressive, like intermittent, I guess, palpitations, or we said episodes instead of intermittent, but.
Okay, like progressive episodes.
I guess we were debating about like acute on chronic because it like acutely worsened was something we talked about. I'm not sure like how that frames into the picture.
And what was on your differentials, so that things that you were trying to potentially highlight?
Well, I mean, we definitely thought about like an anxiety or panic attacks, but obviously you want to rule out, I would have liked to known if she had chest pain or something that would make me think of like, a new ACS, but it's unlikely when it's kind of this chronic process, but it's still something where there is an acute worsening just the other day. So that would make me kind of concerned for that. We weren't sure. I mean, we thought that the sudden cardiac death, given that this is kind of family history, given that this is potentially a cardiac etiology, whether it's like ACS or arrhythmia or something like that.
Yeah, I like it because I think, and the rest of the team can agree or disagree, or the rest of the group too. If you took away that family history of sudden cardiac death, probably all of us would have just been down the road of panic attacks or worsening anxiety. And so I think it makes us pause, which is good. Any thoughts from the team about how this went? How did you all feel? I know it was rushed for time. Was it a good exercise, a bad exercise?
It's a good exercise. I definitely need more practice.
Yeah,
Yeah,
I agree. I need more practice too. So if you ever want to, obviously for the VA folks, I'm in clinic, but love making problem representations in case you have a case that you want to go through. Well, thank you all for your thoughtful comments. So I'm going to go back to presenter mode. So some take-home points. One, your problem representations should evolve as you gather more data, and so continuously try to change them so that you can have that tailored differential while avoiding anchoring bias that can occur when you initially see a patient. Remember that as you gain more experience, your illness scripts will become more nuanced, so then you'll be able to kind of fit more patterns of patient presentations into your system one thinking. But then again, we're all working towards being our master clinicians. So when the puzzle pieces don't fit, slow down and go back to the drawing board and kind of activate your system two thinking. And if you have any questions, I'll stick around on the Zoom until 11 o'clock. But otherwise, thank you so much and have a great break, stretch. Last Zoom lecture, woo, at 11.
Really fast, I wanted to show you how to get to the OneNote content on Teams.